Morton's interdigital neuroma is a painful condition that affects the nerves between the toes, most commonly under the fourth metatarsal head. First described in 1876, it is characterized by a benign fibrous enlargement of the tissue surrounding a common plantar digital nerve. Patients typically experience sharp intermittent pain in the forefoot, which worsens with physical activity or tight footwear. Some may also notice numbness or tingling in the affected toe. Diagnosis is usually based on clinical symptoms, but imaging studies like MRI or ultrasound can help confirm the condition, especially in atypical cases. Treatment options range from simple activity modification and orthotic use to more advanced interventions like radiofrequency ablation, shockwave therapy, or even surgery. However, corticosteroid injections have become one of the most frequently used conservative treatments, offering a non-surgical approach for many patients. Corticosteroid injections are widely used to manage Morton's neuroma, but how well do they actually work? According to a systematic review of studies published up to April 2020, most patients reported satisfactory outcomes within 3 to 12 months after receiving steroid injections. The greatest pain relief, measured by the visual analog scale VAS, typically occurs between 1 week and 3 months post-injection. However, this effect tends to diminish by 6 months and pain may return. Despite these positive short-term results, nearly 30% of patients eventually require surgery due to persistent symptoms. Studies reviewed used a variety of outcome measures, including patient satisfaction scales and objective pain scores, but results were consistent. Steroid injections can provide meaningful, though often temporary, relief for many people with Morton's neuroma. While corticosteroid injections are generally considered safe, some minor complications have been reported. These include skin depigmentation at the injection site, skin atrophy, and fat pad atrophy, though major complications like infection or tendon rupture are rare. The review found that 3 or 4 injections over 6 months seem to be safe for most patients. However, there is still uncertainty about the best type of steroid agent to use, the optimal injection approach, dorsal, plantar, or web space, and the long-term safety of repeated injections. Most studies used intermediate-acting steroids, but more research is needed to compare different drugs and techniques. Future studies should also focus on more objective outcome measures and track results over time to better understand both the benefits and risks of this treatment. In summary, corticosteroid injections offer a valuable non-surgical option for many patients suffering from Morton's neuroma. They provide significant pain relief for most people in the short term, though the effect may not last beyond 6 months for everyone. Minor complications are possible, but serious risks are rare. About 30% of patients may still require surgery if symptoms persist. There remain important questions about the best injection techniques, the most effective steroid agents, and the ideal frequency of treatment. Future research should aim to answer these questions and use standardized, objective outcome measures to help guide clinical decisions. For now, corticosteroid injections remain a practical and relatively safe choice for those seeking relief from Morton's neuroma.